We're taking this, 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 we're taking with a pinch of salt.
Dear ladies and gentlemen, fellow nephrologists, welcome to another episode of A Pinch of Salt. My name is Andrej Koborné. I'm a nephrologist from Slovenia, and this is the episode on BK nephropathy, a very nasty complication of kidney transplantation. It's a real honor that we have with us today Camille Kotton. Dr. Kotton is an infectious disease specialist. She is the clinical director of transplant and immunocompromised host infectious diseases in the infectious disease division at Massachusetts General Hospital. She's also the first author of the second international consensus guidelines on the management of BK polyomavirus in kidney transplantation. The guideline was published last year and has many new information in it, I believe. At least it was new for me, partly. So basically, the perfect guest for this topic, and we're very lucky to have her here today. You can expect to hear about the new recommendations regarding screening of transplant patients, why this makes sense, what to do when we get high BK loads, how to change immunosuppression therapy, and much more. Camille, welcome to A Pinch of Salt, and thank you very much for joining us on this podcast.
Thank you very much. It's wonderful to be with you.
So, first of all, I really have to congratulate you on the guidelines because I found them to be really very well written, very clear on a topic that is very murky and difficult. At least it is for me as a nephrologist. So, thank you for doing that. And off to the first question. And the first question is, according to these new guidelines, all kidney transplant recipients should be screened monthly for plasma BK polyomavirus deanemia loads until month 9, then every 3 months until 2 years post-transplant. So why should we be doing this?
Sure. So, unfortunately for BK, we aren't able to really distill who is at highest risk for developing BK nephropathy. And I think we've all had a lot of surprises with patients that we didn't necessarily anticipate for any particular reason that they would have severe BK nephropathy. We had an outstanding epidemiology group, which is the beginning of the guidelines. And we were hoping that they would be able to, with a very detailed literature review and then with their expert knowledge, that they'd be able to elicit a high risk population. Unfortunately, that's not really possible. It's perhaps in the future we will be able to look at various immunologic factors. It's possible that things like BK cell mediated immunity, or if we had better serologic assays, or perhaps non BK specific markers might end up being predictive. But right now, we do need to screen everybody. And then the best way to prevent BK nephropathy, progression to BK nephropathy, is monthly screening. And it is monthly until month 9. And then and then every 3 months until 2 years after transplant. For kidney pancreas, it's until 3 years after transplant, and also for pediatric patients, because we do sometimes see late disease in those populations. But the biggest issue is to make an early diagnosis and then usually consider reduction of immunosuppression, which is the mainstay of therapy.
Yeah, that's the reason. And the second thing I wanted to ask, because this is also something you state in the guidelines, that this approach is cost effective, that it improves outcomes and quality of life, which is then, that's very convincing arguments to do the screening for everybody. So what's the data behind that? What part of, how does it improve quality of life and outcomes? Cost effective, I guess that's a calculation, but how do the outcomes improve?
So the cost effectiveness data is largely work done by Jermaine Wong and some others, and I was really happy to have a brilliant group of people in the cost effectiveness area. And it might seem like you need to spend a fair amount of money with screening and then responding to screening, the human intervention. But actually, because loss of a kidney graft usually results in returning to dialysis, which is quite expensive. It is believed to be cost effective and in many different medical settings, even potentially low and middle income settings, as well as higher income regions. And so we do recommend, and adhering to the protocol. That's another thing. There was discussion like, could we screen every 3 months or could we screen less frequently? But actually, we probably won't be able to preserve graft function. So that would not be cost effective. As far as overall outcomes, the goal is to decrease the risk of BK nephropathy. And I think, before we had guidelines, before we had a good understanding of what BK nephropathy looked like, we often just sort of patients would come in with a very elevated creatinine. We'd do a biopsy, and lo and behold, they had BK nephropathy. It's sort of akin to having, no monitoring. In the same way that we follow tacrolimus levels and we follow creatinine and we follow things like cell-free DNA potentially and other biomarkers, now we would put BK into that category. So rather than let the house burn to a crisp, we would put things like fire detectors into the house to have an early signal about the risk of BK nephropathy. And then for quality of life, patients are really crushed when they develop BK nephropathy, especially because we don't really have a cure. That is one of the things that came out of the guidelines. And unfortunately, we had initially hoped that perhaps in detailed reviews, some of the therapies would be more effective. But realistically, when we meet with patients and we say, you have significant BK nephropathy, and your kidney function is decreased, and we don't necessarily expect significant return of kidney function. As far as quality of life, that is crushing, and certainly returning to dialysis sooner than we had hoped for is always a disappointment and certainly decreased quality of life.
Yeah. Yeah, I have the same experience in the sense that coming from transplant to dialysis seems to be even worse than going on dialysis for the first time. That's at least how most of my
Mhm.
patients feel. So, okay, you've convinced us that we do the screening, we get these loads, and different labs have different numbers, but you've stated that over 1,000 copies per milliliter or 10,000 even
Mhm.
is something that we should be aware of and start thinking about changing stuff. So let's say we do get a high BKV anemia load. What are we supposed to do then?
So I'm assuming that you're meaning by high, probably greater than 10,000 copies per mil,
Yeah, maybe
or
maybe let's
something,
start off with over 10,000 and then maybe 1,000 to 10,000 for the second
right?
option. Yeah.
So in the guidelines, we have figure one, which is was something that we spent an enormous amount of time debating and honing and revising. But basically, we do recommend, monthly screening for DNA emia, or viral load is what we call it. But because it's not actually viremia, we don't know that it's active virus. It's really just PCR testing for presence of BK DNA. So we call it DNA emia. When we find a DNA emia of greater than 10,000 copies per mil on plasma, if they are high immunologic risk for, rejection, if they're highly sensitized, et cetera, we do recommend proceeding to kidney allograft biopsy because in that setting, we really want to know what is happening in the kidney. So we do recommend with that biopsy to interpret the biopsy results in the context of all clinical, laboratory, and virologic data and prior biopsy findings. And really what we're looking for, is there any presence of rejection, which for which, we obviously wouldn't want to reduce immunosuppression. But if there's no evidence of rejection, we would think about possible reduction of immunosuppression. We would hope that that would be feasible. It can be really challenging, especially if we see evidence of early BK nephropathy. We may, be more encouraged to reduce immunosuppression. This is a really, for the high DNA emia patient, especially if they're high immunologic risk, that is a very challenging situation. If they are not high immunologic risk, but have greater than 10,000 copies per mil on at least one test, we would recommend just proceeding to reduction of immunosuppression and then follow up DNA-emia monitoring and follow up on their creatinine and see how they do. The second scenario would be the sort of 1,000 to 10,000 copies per mil or equivalent, measured twice, at least 2 weeks apart. What we want to do here is make sure that these aren't just kind of very low level blips, of BK-DNA-emia. And so we do recommend in that sort of 1,000 to 10,000 range, checking again with at least 2 weeks apart. And if it is confirmed, then we would recommend going through the same algorithm where you think about the high immunologic risk and potentially having them undergo biopsy. And then is there rejection? Is there evidence of BK nephropathy? And then thinking about cautious reduction of immunosuppression. For those that are that 1,000 to 10,000 without high immunologic risk, we would just recommend proceeding to reduction of immunosuppression and then ongoing monitoring of DNA-emia and creatinine.
Thank you. That's super clear. I'm really excited to have this presented this way, and that's what the guidelines are like. So, um, basically, if you don't have a high immunologic risk and over 10,000, you don't need to do the biopsy. That's good to know.
Yep.
And
Yep.
I guess you also do the biopsy if the creatinine really rises dramatically. And the DNA EMIA is 11,000 for the first time. Then you don't know what's exactly going on, right?
Absolutely. Absolutely. We were actually hoping, so we wanted to maximize what we're doing in that when we really do need a biopsy, we wanted to have biopsies done, but we were also trying to get away from unnecessary biopsies. So there was a tremendous amount of discussion around that topic. I think all of us would prefer to not do a biopsy when it's not indicated. So we did try to hone in on that and maximize diagnostics. I will say that the diagnostics section, which was spearheaded by Parmjit Randhawa, he is terrific, and there's a lot in the guidelines about pathology and then additional diagnostics that's really state of the art.
Yeah, really, really. Everybody should read this if they're interested in BK nephropathy for sure. So, can you explain now how one lowers the immunosuppression? You've mentioned in the guidelines two strategies that one could use, whatever they prefer, I guess, strategy one and strategy two. Can you just quickly tell us how that works?
Sure. So strategy one is reducing the antimetabolite, and that's with reduction of the antimetabolite, in other words, the mycophenolate or the azathioprine by at least 50%. And then if the DNA emia does not decrease by at least tenfold or one log at 4 weeks, or does not clear below the lower limit of detection, we would recommend either discontinuation of the antimetabolite and further tapering of the corticosteroid dose, or if the antimetabolite is stopped entirely, perhaps adding low-level prednisone, such as 5 to 10 milligrams a day, um, to avoid calcineurin inhibitor monotherapy. And then we have some additional steps there, but that's the gestalt is just reduce the antimetabolite by at least 50%. The other option would be to reduce the calcineurin inhibitor. And we'd recommend reduction of the calcineurin inhibitor dose by 25 to 50% in 1 or 2 steps to target trough concentrations of tacrolimus to about 3 to 5 nanograms per milliliter and cyclosporin trough concentrations of 75 to 125 nanograms per milliliter. And then if you don't have at least a tenfold reduction or achieve undetectable levels, then further reduction, which could include reducing the antimetabolite and tapering of steroids and perhaps further reducing the antimetabolite. Now, what was really interesting to me and that I've learned is that at the guidelines meeting, the of about 50 experts, about half really supported reduction of the antimetabolite, and the other half supported reduction of the calcineurin inhibitor. So we felt like these had equal weight. But when I have spoken about these guidelines at multiple different meetings, the Transplantation Society meeting that was in Istanbul, other sort of big international meetings, I find that when I ask for a show of hands of the audience, many people tend to favor reduction of the antimetabolite. So I find that to be interesting. I'm not sure that that is evidence-based. I mean, at the guidelines we reviewed the world's literature, but it is interesting that people tend to favor reduction of the antimetabolite when just speaking with sort of international clinicians.
Yeah, that would be my feeling as well. I think this is
Hmm.
what we do in Slovenia, and whenever I talk to other people, I think that's the first thing they do. I don't know where it comes from. Maybe because CNIs were such a revolution in transplantation that we kind of rely on them to stop the rejection. Although, when you change anything, you can get rejection because of that. And you also mentioned so many people now are on dual therapy, CNIs and antimetabolite. And if you get rid of the antimetabolite completely, then you could add, or you should perhaps add a little bit of steroids, right? That was one thing.
Right,
Okay.
right. Calcineurin inhibitor monotherapy is something we thought should be avoided.
Yeah, that's dangerous, right? And then in terms of treatment goals, you want to see a tenfold reduction initially. And I
Hmm.
think, if I'm not mistaken, you check that after 4 weeks, not before. That
Right.
that's a long time, it seems to me. I think we'd be nervous to know before that, but it seems like that's a good strategy. You don't need to do 2 weeks, you just need to do 4 weeks. That's nice to know.
Yes, I think, I will say that if you have a very high DNA emia, a very high result, and if you're really nervous, you could check, sort of at the 2 week mark. The issue is you might not see the full impact. So you might want to, interpret cautiously and proceed accordingly. Like, I don't know that at 2 weeks you'd already want to reduce immunosuppression further.
Further,
Um,
yeah.
but a thoughtful clinician could certainly contemplate that. But we also wanted to maximize the results of the testing and then clinician reaction. And we didn't want clinicians to be overreacting to too many test points because we wouldn't anticipate such a dramatic fall in the DNA emia at 2 weeks, say.
Yeah. Maybe if you're really nervous, check the creatinine after 2 weeks so that you might be feeling like everything is stable. And then the end goal is to get non-detectable levels in the blood, right?
Yes, yes, whenever possible. I will say that with, the modern era of highly sensitive PCR testing, sometimes I think we uh over like we're too worried about some very low results. I do find people that have, BK levels of, they're sort of 178 copies per mil or IU per mil, and there's a lot of drama around that. So I think the lower levels we don't worry so much about, but we would optimally we would like people to be clearing. If they haven't cleared, I think it's prudent to keep monitoring because you just want to make sure that they're either going to stay very low level or you want to know if for some reason, if the levels might increase again.
So once you've successfully treated, how would they then monitor after that? Let's say that you get the result you want, you get the negativization or very low levels. How often would you screen, or well, not screen, but follow up after that?
So I think there it depends on the individual patient and then what you're doing with the immunosuppression. If it's someone who's at high immunologic risk, and if you say you've cleared the patient's cleared the BK, so you're gradually adding back the immunosuppression, you may wish to keep monitoring them monthly just to make sure it doesn't rear its ugly head again, right?
Mm.
BK is there, it's always lurking, it's like CMV or other infections that are always there. and aren't going to be eradicated or eliminated. So I think it depends on the individual patient and what you've done with the immunosuppression. Probably somebody who's cleared nicely, who's on low dose immunosuppression, you haven't felt the need to increase immunosuppression, needs a lot less monitoring. Maybe you could do monitoring whenever you're checking routine labs versus someone with the high immunologic risk, which I think we're seeing a lot more of these days, more complex transplants, redo transplants, multiple
Yeah.
third and fourth transplants. Those are the ones we do worry about.
Yeah, definitely. And maybe also worth mentioning, you also mentioned the guidelines that if you treat rejection, you should also check for 3 months monthly if you get BK after treating rejection, right?
Yes, yes. So any intensification of immunosuppression, we always worry that that's a time when infection can rear its ugly head. I was taught the phrase rejection resets the transplant clock. Management of rejection resets the transplant clock back to day zero. So I think that's a good concept in that, you sort of think, well, okay, we're back to day zero and we should probably give some CMV, do some CMV prevention, BK monitoring, those type of things. Of course, it depends if you're giving lymphocyte depleting therapy versus, just some steroids. But so it,
Yeah,
it is to be individualized.
that's a good point. One more question. If you look historically at transplantation, in those days where cyclosporin was used as the main CNI, there was, believe, much less PK nephropathy. So at least it was in our center, for example, and I believe that
Mm,
there's some experience like that elsewhere as well. So does it perhaps make sense to change from tacrolimus to cyclosporin? Let's say it's a patient that's not at high immunological risk. I
mm.
guess there's not data for that, right?
No, that's not a recommendation. It is an interesting observation. I think we did a lot less monitoring for BK back then as well. So I'm not sure, in the modern era with tacrolimus, we've done a lot more monitoring and we're a lot more aware. So I think there could be multiple factors that seem to muddy those waters. It's interesting. We had been cautiously optimistic that perhaps switching to mTORs, sirolimus, everolimus, that perhaps that would be helpful. We've sort of thought about that a lot with CMV. We know that when mTOR inhibitors are used as primary immunosuppression, in seropositive patients that seropositive for CMV patients, that they have much lower rates of developing CMV. And we were cautious optimistic that if we had patients with BK switch to mTOR inhibitors, that they might have a much better outcome. But the group in Strasbourg, Sophie Caillard's group, and others who participated in a very nice study looking at switching to mTOR inhibitors actually saw a lack of effect there, and it actually was less optimal. So that's why we do clinical trials. That was really disappointing, I have to say. Yeah, I wish we could just juggle the immunosuppression and do better. One of the things that came out of the guidelines is that really none of the treatments that people are doing, the leflutamide, the cidofovir, all kinds of stuff, we do not recommend outside of clinical trials. The only thing for which we had a soft recommendation would be use of intravenous immunoglobulin. And I think most of us think that that has not much of an impact, but is really the only thing for which there's minimal data. I am excited in that there are a couple of things coming down the pipeline. Mimo Therapeutics just had its phase 2 data discussed at the World Transplant Congress, and that did look interesting in phase 2 data. And hopefully they'll go on to phase 3 studies. And then Icuris has an oligonucleotide that just finished phase 1 studies and looked, safe and interesting, and could be therapeutic. So they're starting a phase 2/3 study, I believe, next year. So there are
Mm.
some things coming down the pipeline. Hopefully everyone can sign up to be a study site if you are approached. We'd love to have more data. Um, but for now, unfortunately, there are not a lot of good therapeutics, which is really, some people say it's the best part of the guidelines because there was a lot of kind of unusual treatment happening, fluoroquinolones, all kinds of things. But we
Yeah.
basically said, please don't do that.
Yeah, that's good. That's helpful to know for sure. Now, the penultimate question is a really tricky one,
Mhm.
maybe less tricky than the last one, but it's still tricky. So sometimes you get a biopsy, like a significant rise in creatinine, you get a biopsy, and it looks like rejection histologically, but also the BK, the anemia levels is high. Maybe you even get some staining in the tubules. So it likes it. The pathologist can't really say it's one thing or it's the other thing, or maybe it's both. So historically, we usually went for IVIG as like something that might benefit both. But how would you tackle that unfortunate situation?
Yeah, that is, I think, the hardest one of them all, as you said. And I think sitting down with the pathologist, doing a detailed review, making sure that the pathologist has really spent a lot of time and that you feel quite familiar with the biopsy yourself. And then, yeah, if it really shows presence of both, which is really the hardest case scenario and potentially the situation where you are least likely to win. I mean, it's really hard to balance those two forces. We certainly, I know in my institution, we definitely would use IVIG. I we hope that that's helpful. We don't know how helpful it is. I say hopefully we're treating the patient. The doctor definitely feels better giving IVIG. The doctor themselves feels better.
Definitely,
Hopefully we're
definitely.
helping
Yeah.
right? At least somebody feels better. Those are very, very hard situations and will require very diligent follow-up, but there is a high rate of loss of the graft in that situation, which is just challenging. We do have a recommendation for repeat transplant for people who have lost a graft to BK nephropathy. We don't have recommendations around altering the immunosuppression with a redo transplant. We do recommend that people have fully cleared the DNA prior to redo transplant. And we also, although we had great debate, we don't recommend explanting the prior kidney transplant graft. So people can safely go on to redo transplant. And I think that was also one of the big things that came out of the guidelines that people were happy to hear that they could do a repeat transplant.
Yeah, that makes it much easier without taking the old transplant out. Urologists are not very keen on that, at least in my place. So the last question, which is the one that all our viewers or listeners who have already listened to our podcast already know, which is which book, two songs, and luxury item would you take to a desert island?
Yes, so that is a very challenging question. But I just read Jacinda Ardern's autobiography, A Different Kind of Power, and I thought it was terrific, really candid, really interesting hearing the story of a relatively young female leader who had a lot of important decision making, especially during the COVID-19 pandemic. And I just thought it was a terrific read, and I would certainly recommend it for many people in academic medicine because there are a lot of parallels for all of us. The two songs, I would definitely bring Landslide by Fleetwood Mac and I think almost any song by Jackson Brown, but perhaps Doctor My Eyes by Jackson Brown. And I think my luxury item would be my husband.
Haha, that's nice. That's very nice.
Mhm.
Thank you for that. Yeah, I don't know. I found out that song from Fleetwood Mac, although I have to admit I've only listened to rumors, more or less. So I'm not a big brainiac for Fleetwood Mac. And Jacinda Ardern, that's a very nice suggestion. I listened to a podcast with her. It's the podcast is called The Rest is Politics, from two British politicians. A very interesting podcast they have, and she was very inspiring. She also quoted a New Zealand politician of an older generation. I can't remember his name, but I thought the idea behind that was very nice. He said that everybody needs four things in their lives. They need to earn money, they need a roof over their head, they need love, and they need hope.
Mhm.
And I find that to be very, very true. Money, house, and love is not entirely enough. You need to have
Mm,
hope that something will happen in a better way at some point. At
mm.
least
That's
nowadays, I guess, but maybe always, who knows.
Yeah, that's beautiful. That's beautiful. Well, I hope that the BK guidelines have given transplant clinicians hope that they can save and expertly manage a lot more kidney grafts. So, yeah, hopefully I've provided hope through the guidelines. And I'd just like to say how appreciative I am to all my colleagues who contributed so much. It was a wonderful international collaboration. Thanks for having me.
Thank you, Camille. You really know what you're talking about. So thank you for sharing this with us. And well, I guess have a great day.
Thanks. You too.